It's great to be here today, and thank you all for coming. I would like to talk with you about cost in a slightly different angle than you might be used to. So I'm going to frame healthcare costs as it relates to vulnerable populations. I think that as we talk about this, you will be able to take some of these lessons and relate them to other groups. So in order to do this, what I'd like to do is start by giving you an overview. If you don't have an overview of caring for homeless individuals, it's a little bit hard to put these concepts into context. So I just want to paint a picture for you for who homeless individuals are. We all have a sense of homeless individuals by what we see visually on the street and maybe what we interact with in the healthcare system. Here are just some numbers so that you have a sense of who we're talking about. So about 2.3 to 3.5 million individuals are homeless at any time. It's about 1% of the US population goes through a period of being homeless. About a third of those at any given time are children. It's a majority male population, about 77% male, and families are the fastest growing segment of the population. If you remember anything about homeless demographics, think about this. Families have not grown this much in homelessness since the Great Depression. It's getting worse as the manifestations of the Great Recession continue. And when you think about families in homelessness, it's an invisible problem because in the United States we aren't quite ready yet to see children on the streets. So it's a hidden problem. I want you to be very aware of it. This is also an issue of healthcare disparities. 49% of homeless individuals are African American, 13% Latino or Hispanic, and 40% served in the armed forces. So it's a huge issue at the level of veterans. And of course, this is a group that's very impoverished. As I go through, I'm going to put in a plug for a couple of things. And one is you can see that this data is old. I'd like to assure you that it's the most recent data that's available. There's about 10 of us in the country who are interested in studying issues related to homeless health. So those students of you in the audience who want to come and work with me on this topic, it's a great area for further study. And looking at the numbers a little bit closer, if you look at a one-night count, the most recent U.S. data that's available is from 2010, and it's about 650,000 countable individuals, which is an increase from the year before. The Boston one-night count, again, if anyone's interested in going with us to do this count, we literally hit the streets on a Monday night in December looking for homeless individuals and then collaborate with who's in shelters and who's in prisons and who's in hospitals to get this count. The countable individuals are about 7,000, probably doesn't seem like that much. If you look at the number that we see at our Healthcare for the Homeless program, it's 12,000 a year. And if you extrapolate from shelter data, it's about 25,000 individuals in Boston who are homeless. I give you these numbers for a couple of reasons. One, so you can understand when I give you cost data what the context is of how many individuals we're talking about, but also so that you understand that any numbers that you see are a vast underrepresentation. The individual that you see lying on the floor here, who's a patient of mine, that's probably the image you have of homeless individuals. That's the chronically homeless group who often sleep outside or in shelters and have been homeless for over a year by definition. It's only about 10% of the population. There may be somebody in this room who's been a victim of being transitionally homeless, which is about 80% of the population. And those are most homeless individuals who come in and out of homelessness quickly because of a fire or domestic violence issue or some other catastrophic life event, but it's a transient issue. Those are the individuals for whom the shelter system was set up, but what's happening is that the shelter system is mostly being used in a heavy way by those who are chronically homeless, which is 10%, or episodically homeless, coming in and out of homelessness, which is another 10% of individuals. And those are the individuals who contribute most to the cost of being homeless, and consequently, one of the biggest costs, which I'll show you of being homeless, is around health care for homeless individuals. When we're talking about healthcare costs for homeless individuals, these are some facts, many of them data-driven and some of them clinical observations. So when you're talking about a homeless individual, you're talking about increased mortality, increased chronic medical illness, increased mental illness and addiction, multiple barriers to medical care, fragmented and crisis-oriented care, medical follow-up that's lacking, and no sufficient place to recuperate. I'll show you some numbers to support these facts, but when you think about healthcare cost and building systems to improve healthcare efficiency, this population is very important to take care of, because these challenges are not challenges that all of us have, and unless we take these challenges into account, we can't properly think about how to distribute costs for these individuals. This is some data that I put together. It's in press at American Journal of Public Health, myself and my colleagues, and this is looking at a cohort of 6,500 patients of ours at Boston Healthcare for the Homeless, and looking at Medicaid claims data to look at what kind of medical illnesses they suffer from. And I'm going to show you these next couple of slides to show you how very profound the burden of diseases in these individuals. So if you look at this mental illness in this cohort for Boston Healthcare for the Homeless, 68% have mental illness. It's a vast majority. Substance use disorders in 60%, and co-occurring mental illness and substance use in 48%. So you're entering into a population where there's a very high burden of behavioral health illness. Behavioral health illness, as I'll show you, is a great contributor to cost in healthcare. Here are some common medical illnesses, just to put this into perspective. This is that same cohort of 6,500 individuals. And if you look at their medical disease burden, so hepatitis C, which is an inflammation of the liver that can lead to end-stage liver failure, in the general population, it's less than 2%. The prevalence in this population is 23%. All of these diseases are more prevalent in this population than the general population. Even some common diseases, such as diabetes, in this population it's 18%. In the general population, it's 8%. When you talk about caring for diabetes in someone who's homeless, you have to think about things like getting regular meals, getting appropriate exercise, storing medications, taking medications and not having your sugars go too low, as well as storing insulin and needles. So it really gets complicated by the socioeconomic situation that an individual is in. And we know from the general population that there's lots of data on untreated diabetes leading to unnecessary healthcare costs in the system. Tobacco use is also extremely prevalent. When you think about healthcare disparities, this population of homeless individuals nationally, and this has been documented locally in Boston, this prevalence of current smoking of 73% of the population is the highest subgroup recorded anywhere. The highest minority group that's known to have the highest prevalence rate of tobacco use is in Native Americans, which is 29%. So this subgroup has a 73% smoking prevalence and a very low lifetime quit rate. Again, these are contributors to the high cost of healthcare in this population. When you look at homelessness at a national level, you see a lot of unmet need. You should be proud to know that Boston and Massachusetts have decided through policy efforts to provide health care for most homeless individuals. And this didn't come with Romney Care or Obamacare. This came before that in the 1990s, when Massachusetts as a state said impoverished individuals who are unemployed for greater than a year will automatically get Medicaid or Mass Health. So it's an example of how in Massachusetts we've made policy decisions that have therefore improved health for individuals. At a national level, there's a vast amount of unmet need for homeless individuals. Much of it is due to access of care, and you'll see some numbers here, but 73% of homeless individuals nationally have some unmet need. And we can talk maybe during the question and answer period about how unmet needs for preventive and routine care lead to increased healthcare costs later. If you aren't convinced yet about the high burden of disease and morbidity, I'll show you some data on mortality. This has been repeated several times, but this data is from a cohort of individuals who we looked at in Boston, and it's looking at over 18,000 individuals and comparing death records and our medical records. And you'll see that the average age of death is 51. So again, thinking about the healthcare disparities and the disparities in care, where this is not life expectancy, but it's average age of death. But in the United States, and this is in what many call, the Mecca of medicine in the world, in Boston, the average age of death of a homeless individual is 51. You'll see the causes of death here. In the young, it's still drug overdose. But as individuals who are homeless get older, it becomes more bread and butter medical issues, such as cancer and heart disease. And remember, I showed you the prevalence of tobacco use. That prevalence of tobacco use, you won't be surprised to hear the most common cancers are lung cancers, head and neck, and other tobacco-related cancers. So this is data. I told you we had that cohort of 6,500 individuals who we looked at 2010 Medicaid data. And this is breaking up that cohort looking at disease. So if you look at the individuals, and the numbers are down below, you'll see that if somebody has a diagnosis of COPD or asthma, their annual cost for caring for that individual is over $36,000. That's not just to care for that disease, that's total cost. But the presence of COPD or asthma makes that individual's cost to the system $36,000. The highest one is congestive heart failure at over $78,000. If you look at Massachusetts-wide data, depending on where you look, it's about, on average, we spend $6,000 per individual for their annual healthcare costs. So compare that to some of these chronic medical diseases. Furthermore, if you break it down looking at behavioral health illnesses, look at this. When there's no behavioral health diagnosis in this group of homeless individuals, the cost of caring for them is actually the cost of caring for all of us. It's about $6,000. When you add a substance use disorder, it goes up to $13,000, and a mental health disorder up to over $30,000. So when we looked at this cohort, on average, given all of these cofactors, it's about $22,000 a year to care for them. So $22,000 to care for a homeless individual in Boston. And I must tell you that this is a medical cost. So this does not take into account any shelter care, any food care, any soup kitchen care, police, correctional services. It's simply around the specific medical costs that are recorded in Medicaid and Medicare. So what's contributing to this cost? It's no surprise, it's the things we hear about most. Number one is inpatient stays, which contributes to 40% of the cost. So if you look at this here, you'll see that the 66% don't have an admission, but the rest of the individuals who have an admission is much higher than US averages. So only about 8% of the US population gets admitted to the hospital. And even in other complex patients, like dual eligible individuals in Massachusetts, that rate is 18%. And we have over 30% of our patients getting at least one admission. And I draw your attention to the greater than 9. So there's 2% of this population who's having more than 9 admissions to the hospital in a year. Another etiology of the high cost comes from the use of emergency departments. Those of you who are interested in cost control will have thought and read a lot about the use of emergency departments for unnecessary medical visits. So here's the data for this group of homeless individuals. So on average, this cohort of 6,500 homeless individuals in Boston use the emergency room 4 times in a year. Again, that's greater than any national average. And if you look at, there's about 477 individuals who we call the super high users who had greater than 12 visits to the emergency department in a year. So some of these visits are for medically necessary interventions, but not all of them. So this looks at, again, just comparing this group of individuals to a Medicaid statewide population. So just to orient you on what you're looking at, so there are 426,000, that's a statewide. So anybody who's on Medicaid in the PCC plan, it's one of the primary care plans. and then comparing that to almost 4,000 individuals who are patients of Boston Healthcare for the Homeless. And if you look at this, the DXCG score, which some of you may be familiar with, it's a way to risk stratify individuals to look at their burden of disease and to look at prediction models to say how much they might cost in the year to come. The bottom line is homeless individuals are predicted to cost almost 3 times as much as another poor individual who's covered by Medicaid. And if you then look down the chart, you can see some of the reasons why, with a higher prevalence of behavioral health issues and common medical diseases, as I pointed out to you, such as asthma and diabetes, and more use of the hospital and ED. And then the average annual cost, again, is over $20,000, and this is, again, just the medical part of the charges. So I don't know if I needed to convince you or not that this is a group that has high morbidity, high mortality, and are very expensive users of the medical system, but here's the data that supports that. And if that's not enough, even within this, I mentioned the super high users. If you look at the top 650 individuals in that group, so 10% of the users, they are responsible for about half of the cost. This is true in many medical systems, but it's really a profound difference here, where it's over $100,000 for each of those 650 individuals. So those of you who are problem solvers in the audience, just think, if we know who these 650 individuals are, or if we can predict who they would be in the year to come, what we could do to change that healthcare cost. Now I want to frame that in reference to what our program does at Boston Healthcare for the Homeless. I'm going to talk to you a little bit about the model, and then I'm going to talk to you a little bit about some of our cost-containing strategies. I want to warn you that there's not a lot, the data on it costing a lot, all of that data that I showed you is relatively new. It's inexplicably hard, not inexplicably, but it's harder than you would think to obtain data from sources that collect data on cost, diagnoses, and claims, and to be able to then take that and turn it into actionable steps. So let me talk to you a little bit about our program. So the mission of the program is to either provide the medical care directly or to provide access to medical care for homeless individuals in and around Boston. We also are taking care of many more housed individuals because there's been a great effort to house more chronically homeless individuals, both nationally and at the city and state level. So about 20% of the individuals we take care of are vulnerably housed. The model is a model that it's actually become very fashionable to talk about being patient-centered, and it's fashionable to talk about a team-based approach and culturally competent care. This is a model that we put into place almost 30 years ago. It's the only way we find we're able to care for vulnerable homeless individuals. The picture that you see there is one of our nurses speaking to a homeless individual in the park. And on the floor, seated, unfortunately you can't see her, is Jill Roncardi, one of our PAs, graduated from here, who are trying to engage an individual in medical care and get him to at least let them give him a flu shot. So when we talk about being patient-centered, it's about meeting a patient where they are. So we go to 80 different sites in and around Boston in an outreach model. So instead of waiting for the person with diabetes to come to the emergency room or come to the clinic when their sugar is 500 and they need to be admitted to the ICU, we're going into the shelters and doing education around their meals, helping them take their insulin, giving them a place to store their medications, so that we're trying to go upstream of the ICU visit and do something for that individual early on. Engaging people in care. Remember, I told you about the high level of behavioral health illness and the burden of that. And a very important part is engaging people in a way where they can feel that they can build trust with you. The team-based model is about individuals from all disciplines working together to care for the patient. We have about 20 physicians in our group, but over 100 nurses. So it's very much a team-based model where every member has a role. The cultural competency, which you've heard is a term, the importance of that is understanding where an individual is coming. So if you're giving, I'll give you a very short example. There's a woman who I took care of who used to be a surgical tech at one of the academic medical centers. She had a domestic violence issue and lost her housing and ended up on the streets. She had congestive heart failure, for which she had to take a diuretic, Lasix. Whenever she was in the hospital, she took it. When she was staying with us at our medical respite, she took it. Whenever she was outside, she didn't. She would end up back in the hospital, be admitted to the hospital, cycle through, stabilize with us, and then back on the street. When you ask this, people were very frustrated with her because the cure for her issues would be to take her medication. It would cost less for the system and it would be better care for her. When you ask her why she didn't take her medication, the reason was that she wouldn't admit to everyone is that a diuretic makes you have to go to the bathroom. And she said, as a woman in Boston, you tell me where you can quickly find a place to go to the bathroom when you're homeless. So this kind of cultural competency of thinking about how individuals manage their care and how that problem could lead to her bills being, she's one of those women in the greater than 100,000 group. So this is just some of the realities of homelessness, which I think I've stressed already, and in the interest of time, I'll skip over, except to show you this picture. This is the Longfellow Bridge, the Salt and Pepper Bridge, and that's that same nurse going to visit an individual who has made a makeshift bed for himself. You go up high so that if some security individuals come by, they don't see you sleeping there. So they sleep up high, and then right above that pavement is where the cars go. And in that bag, she's delivering him his medications. So this is an example of that outreach model to keep people out of the hospital. So it's a citywide collaboration. The reason this model works is because all of these groups are vastly intertwined and communicating to provide these patients with a medical home where they can get the services wherever they are. What data do we have to prove that it's cost effective? Is it the right thing to do? Is the moral compass in the right place? Are we proud of the high quality of care we're providing? Absolutely. Is this the care that you all want the homeless individuals in Boston to get? Absolutely. We're here to talk about healthcare cost. Let me tell you a little bit about patient-centered medical home. Any of you have heard of this? It's a program that looks at giving a patient a medical home where they can have their care coordinated, have very high complexity patients, have care management to provide high quality care. Boston Healthcare for the Homeless has become accredited at the highest level, so we're this medical home for individuals who are homeless. And through this care coordination, we have noticed improvements in the work that we already do to coordinate care that have resulted in palpable benefits. The ones that we can measure are quality benefits. You have to take the leap of faith to say if we improve quality and preventive care, it will improve long-term costs. We can debate that. But this is just to show you some of the quality improvements related to patient-centered medical home. The red line is where the patients have gotten who are part of this patient-centered medical home. It's not throughout our program, so you'll see that the blue line is where the patients are who are not part of the patient-centered medical home. It's not a controlled study, but it gives you a sense that the patients do have more breast cancer screening when they're part of this patient-centered medical home. Same applies for colon cancer screening, which is incredibly challenging to do in a homeless population. The patients who are in the patient-centered medical home have improved rates of colon cancer screening versus our general population. The other thing that we're doing is, and this will make sense to you in a second, is talking about process improvement. So our goal, we're a federally qualified neighborhood health center, and our goal is to eliminate as much waste as we can from our system. There's a lot of talk in healthcare cost control around waste and how do we eliminate waste and redundancy. So we are training our personnel in lean technologies and process improvement technologies so that we can think within our system how to improve the efficiency that we provide. So this, for example, just to give you a visual flavor, is the admissions process into our medical respite. We run a 104-bed inpatient facility for homeless individuals. And those little stickies, each one of those is a step. We sent a team through a lean process training so that they can redesign the program. And without looking at the details of what it entails, they took it from that 38-step down to this 11-step process, saving the patient 5 hours in the process. So thinking about ways to improve cost control by teaching our staff process improvement. 2 more examples and then I'll hand over the mic. So if we're going to think about cost control, we have to all think together about innovative ways to care for individuals that are less expensive. So one of those that you may have heard about is community health workers or community support workers who go into the community and do navigation, education, and companionship for patients to get them where they need to be and to allow them to have patient activation. We've piloted this program. Remember, part of the issue is that our current healthcare system is fee-for-service, and in that system there is no way to pay for these individuals. So these programs that we have are all grant funded. That's important to think of as we think about how can we improve care if we go to a global model. So in this model, on the little bullets you'll see are all quality improvements. But if you look at the bars, you'll see that the patients who had interventions with these community health workers had 9% decrease in hospital utilization and a 60% decrease in ED utilization. So I showed you where the costs are for our population. So if we can put into place programs that decrease ED use and hospital use, can we bring down the cost and look at this also improve the quality of care that patients get? Another final example is I want to tell you about this project called the High Users of Emergency Services to Home program. So Hughes to Home. So this program is really about going upstream. Part of the cost for caring for homeless individuals is because they don't have a stable home. So could we improve health by improving housing outcomes to decrease utilization of unnecessary medical costs? Here's our preliminary data. It's only 26 individuals and it's not published yet. But if you look at this, it's that same concept. Before housing is in gray, after housing is in blue. When we house individuals, they have 56% reduction in emergency department visits, 33% decrease in inpatient visits, and 86% decrease in EMS service use. So decreasing cost by housing individuals. I forgot I have this one. This is really cool. It's also unpublished, but I told you about our McGinnis house. At our McGinnis house, which is a 104-bed inpatient facility, we allow the local hospitals a place to have homeless individuals get their care that's not acute level care. So tracking, this is simply looking at 20 individuals who got intravenous therapy with us versus if they would have stayed in the hospital. And you can see the cost with us, $88,000, and almost $1 million for those individuals if they would have stayed in the hospital. So having appropriate, lower cost alternatives for high cost subsegments of the population works. And here's an example. So in summary, where are the cost savings, at least for the populations that I care for, vulnerable, high cost populations, but I believe this can be taken and extrapolated to other populations. It's in the more coordination, more care management for high-risk individuals, education for staff on process improvement, and moving upstream from the problem, in this case to housing.